Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of acute tonsillitis and pharyngitis in children, designed for general pediatricians and exam candidates. Sore throat is one of the most common reasons children present to outpatient clinics and emergency departments, yet distinguishing benign viral pharyngitis from Group A streptococcal infection, infectious mononucleosis, and dangerous deep neck space complications remains a daily clinical challenge. We will work through 10 carefully crafted clinical cases covering clinical recognition, examination findings, pathophysiology, diagnostic workup, differential diagnosis, antibiotic selection, complications, and special situations including penicillin allergy. Let us begin. Case 1. A 7-year-old boy presents in January with sudden onset of sore throat and fever of 39.2 degrees Celsius for 1 day. He reports headache and abdominal pain. There is no cough, no rhinorrhea, and no conjunctivitis. On examination, bilateral tonsillar erythema with exudates, tender anterior cervical lymphadenopathy, and palatal petechiae. What is the most likely diagnosis? Option A. Group A streptococcal pharyngitis. Option B. Infectious mononucleosis. Option C. Viral pharyngitis. Option D. Peritonsillar abscess. The correct answer is option A. Group A streptococcal pharyngitis. This case demonstrates the classic textbook presentation. The sudden onset of high fever, sore throat, tonsillar exudates, tender anterior cervical lymphadenopathy, and palatal petechia together form a highly suggestive constellation for Group A streptococcal infection. Equally important is the absence of viral features. The lack of cough, rhinorrhea, and conjunctivitis strongly argues against a viral etiology. The peak age of 5 to 15 years and the winter and early spring seasonality both fit Group A streptococcus perfectly. Headache, abdominal pain, and vomiting are common associated symptoms in children with streptococcal pharyngitis and should not be mistaken for a primary gastrointestinal illness. Case 2. A 10-year-old girl presents with 2 days of severe sore throat, fever of 38.8 degrees Celsius, and difficulty swallowing. On examination, you note a unilateral bulging of the left peritonsillar area, deviation of the uvula to the right, trismus, and a muffled hot potato voice. She is drooling and appears uncomfortable. What is the most likely diagnosis? Option A. Retropharyngeal abscess. Option B. Epiglottitis. Option C. Peritonsillar abscess. Option D. Ludwig angina. The correct answer is option C, peritonsillar abscess. A peritonsillar abscess is a collection of pus between the tonsillar capsule and the superior pharyngeal constrictor muscle. The classic triad consists of unilateral peritonsillar bulging, uvular deviation to the opposite side, and trismus, which is caused by irritation of the pterygoid muscles. The hot potato or muffled voice and drooling reflect the patient's inability to manage oral secretions. Peak incidence is in adolescents and young adults aged 5 to 25 years. Retropharyngeal abscess typically affects younger children under 6 years and produces neck stiffness with posterior pharyngeal bulging. Epiglottitis presents with tripod position and stridor. Management is needle aspiration or incision and drainage, plus intravenous antibiotics covering streptococci and anaerobes. Case 3. A 6-year-old boy is diagnosed with Group A streptococcal pharyngitis. His mother asks about the importance of completing the full antibiotic course. She mentions that her neighbor's child developed heart problems after a throat infection that was not treated. Which virulence factor of Group A streptococcus is most directly responsible for the immune-mediated cardiac damage seen in acute rheumatic fever? Option A. Streptolysin O. Option B. Hyaluronidase. Option C. Streptococcal pyrogenic exotoxin. Option D. M protein. The correct answer is option D, M protein. M protein is the major virulence factor of Group A streptococcus, with more than 240 known types identified by EMM gene typing. It is an antiphagocytic surface protein, but its critical role in rheumatic fever lies in molecular mimicry. M protein shares structural epitopes with human cardiac myosin and heart valve tissue, particularly the mitral valve. When the immune system produces antibodies and T cells against M protein, these cross-react with cardiac tissue, triggering rheumatic carditis. Certain EMM types, such as type 1, are strongly associated with rheumatic fever, while EMM type 12 is more associated with post-streptococcal glomerulonephritis. Streptolysin O is a cytolysin and the basis of the anti-streptolysin O titer test, but it is not the primary driver of cardiac damage. Case 4. An 8-year-old girl presents with sore throat, fever of 38.5 degrees Celsius, tonsillar exudates, and tender anterior cervical lymphadenopathy for 1 day. She has no cough or rhinorrhea. A rapid antigen detection test for Group A, Streptococcus, is performed and returns negative. What is the most appropriate next step in management? Option A. Obtain a throat culture. Option B. Start empiric amoxicillin. Option C. Reassure and discharge with symptomatic care only. Option D. Order an anti-streptolysin O titer. The correct answer is option A. Obtain a throat culture. The Infectious Diseases Society of America recommends that in children and adolescents aged 3 years and older, a negative rapid antigen detection test should be followed by a backup throat culture. This is because the rapid test has a sensitivity of only 70 to 90%, meaning up to 30% of true infections may be missed. The throat culture is the gold standard with sensitivity of 90 to 95%, although it takes 24 to 48 hours for results. This child has high clinical suspicion based on the modified Centaur or Mac-Isaac criteria, so empiric antibiotics without confirmation are inappropriate and promote resistance. Anti-streptolysin O titers are only useful retrospectively for diagnosing prior infection in the context of suspected rheumatic fever or post-streptococcal glomerulonephritis, not for acute pharyngitis. Case 5. A 15-year-old boy presents with 5 days of sore throat, fever, and profound fatigue. On examination, bilateral tonsillar enlargement with exudates, posterior cervical lymphadenopathy, and palpable splenomegaly. A rapid strep test is negative. A complete blood count shows atypical lymphocytes of 20%. What is the most likely diagnosis? Option A. Group A streptococcal pharyngitis. Option B. Acute human immunodeficiency virus infection. Option C. Infectious mononucleosis. Option D. Acute leukemia. The correct answer is option C. Infectious mononucleosis caused by Epstein-Barr virus. Several features point strongly to this diagnosis. The classic triad of fever, pharyngitis, and lymphadenopathy, especially posterior cervical lymphadenopathy, is highly characteristic. Splenomegaly is present in approximately 50% of cases. Profound fatigue lasting 1 to 3 weeks is typical. Laboratory findings show atypical lymphocytes greater than 10% on the peripheral blood smear, and the diagnosis is confirmed by a positive heterophile antibody test, commonly known as the monospot test. A critical clinical pearl: never give amoxicillin or ampicillin to a patient with infectious mononucleosis because it causes a characteristic non-allergic maculopapular rash in up to 90% of patients. Patients with splenomegaly should avoid contact sports for at least 3 to 4 weeks to prevent splenic rupture. Case 6. A 6-year-old girl weighing 20 kilograms is diagnosed with Group A streptococcal pharyngitis, confirmed by a positive rapid antigen detection test. She has no known drug allergies. Her parents ask about the best treatment option. What is the most appropriate first-line antibiotic regimen? Option A. Azithromycin 12 mg per kilogram on day 1, then 6 mg per kilogram for 4 days. Option B. Cephalexin 20 mg per kilogram per dose twice daily for 10 days. Option C. Clindamycin 7 mg per kilogram per dose 3 times daily for 10 days. Option D. Amoxicillin 50 mg per kilogram once daily for 10 days. The correct answer is option D, amoxicillin 50 mg per kilogram once daily for 10 days with a maximum dose of 1000 mg. Amoxicillin and penicillin V remain the first-line antibiotics for Group A streptococcal pharyngitis worldwide. A remarkable fact in modern microbiology is that there has never been a documented case of penicillin resistance in Group A streptococcus. The full 10-day course is essential not just to resolve symptoms, which improve in 3 to 4 days, but to eradicate pharyngeal carriage and prevent acute rheumatic fever. Once daily dosing of amoxicillin improves compliance compared to multiple daily doses. Alternatives such as cephalexin, azithromycin, and clindamycin are reserved for patients with documented penicillin allergy. Intramuscular benzathine penicillin G is a single-dose option useful when compliance is a concern. Case 7. A 9-year-old boy presents 3 weeks after an untreated episode of pharyngitis with new-onset migratory polyarthritis affecting his knees and ankles, fever of 38.5 degrees Celsius, and a new cardiac murmur. His erythrocyte sedimentation rate is 65 mm per hour, and his anti-streptolysin O titer is elevated at 400 international units per milliliter. Which of the following is a major criterion in the revised Jones criteria of 2015 for diagnosing this condition? Option A. Elevated erythrocyte sedimentation rate. Option B. Erythema marginatum. Option C, prolonged PR interval. Option D, arthralgia.